concept of iPENDO has been there for quite some time, because we have been trying to solve problems in a easy fashion, so that we are able to really identify and evaluate complicated pediatric endocrine problems in an appropriate fashion. Number of approach pathways which will allow you to approach to a particular endocrine condition, manage pathways, calculators, diagnostics, therapeutics, and knowledge bank. So it's like, how does it work? We have got 31 approach pathways, which basically covers every condition that you will encounter as pediatric endocrinologist. We have got around 13 management pathways which cover the various possibilities. And when you talk about these pathways, they actually look simple when you solve them, but they are actually very complicated algorithms. So there are various weightages which are given to different situations, so that we want to select the lowest resources required to reach a diagnosis. So if you want to evaluate for growth failure, we would like to keep IGF-1 at the end. If you want to evaluate for some complicated calcium disorder, we'll keep calcitriol at the end. So the algorithm is designed so as to ensure that it is resource appropriate and the cost-benefit ratio is there in that situation. Then we provide personalized, prescriptionized management, and we'll discuss that all throughout that. Now, it basically is a very simple user interface. You just go to the disorder you're looking at, and then you answer a few questions. Yes, no, you will get the answer, and we'll go through about that in that situation. Now, this is available at both the Android as well as the iOS platforms. You can just go and download from there. All you have to do is to register. You will have a free access for 7 days for the entire app, in which you can look through. After that period, you will have access to specific things which are essential, like growth interpreter, like DK. A few of them will remain. Others are for a very nominal subscription in that regards. Now, many of these courses come bundled with their subscription. So if you take the course, automatically the bundle becomes from there. Just to go through a bit, the approach pathway basically uses evidence-based algorithm approach. And the way it is that you have to choose a condition. So suppose you want to approach delayed puberty in boys, you will answer a few questions, and all these are taking you to one section of algorithm. Now, there will be around 100 possibilities which are there, but you will reach, like in this case, we have reached 17 beta HSD deficiency. So it will end up at a particular diagnosis. Now, this is counterintuitive, but this is going to be quite helpful in reaching a diagnosis when you don't have access to expertise, which is not there everywhere. The management pathways similarly use the algorithmic approach. So like if you have hyperkalemia, it will ask the level of potassium, ECG changes, and it will guide you through with emergent management. So all your protocols are pretty much there. You don't need to go ahead and read it, and we give information specifically about doses also if it's required at that point of time. The diagnostic sections was developed largely by Dr. Riddhi, and it provides extensive information. So if you want to prescribe a test, it will give you all the information which is relevant, and every single test which is there in pediatric endocrinology is provided there, along with ranges which are difficult to find often in that situation. The therapeutics by Dr. Sajili has around 64 drugs used in pediatric endocrinology. If you want to know about any in terms of doses, indications, contraindications, you will get all information about a particular drug. Like for desmopressin, it provides this information. So, and that's where DKA becomes important. Now, when we talk about treatment of DKA, there are various components of treatment. What is the most important part of treatment of DKA, Simon?
So the
first part.
So dehydration.
So fluid. Fluid is the most important part. When you give fluid, what will happen? How much the sugar will come down with just hydration?
So 50 to 100.
100 to 200. It may go up more than that. Why? Why does it come down when you give them fluids, Narayan? So just by giving normal saline, why does the sugar come down?
So one is the dilution effect, and when the hydration status is corrected, the excretion also increases.
So I'm third. So of course, when you give fluid, you are in less volume, your concentration will be more. When you expand it, your concentration will become less in that sense. The second important is your counter-regulatory hormones will go down. When your response to hypovolemia goes off, your growth hormone, your cortisol, your epinephrine will come down, and therefore your glucose will basically start to come down. And you expect around 100 to 200 milligram per DL fall in glucose by just giving the bolus. But if you just give fluid, the child is not going to be fine because your ketogenesis will continue. To discontinue the ketogenesis, you need to give insulin. And with insulin, your ketone will come down and there will be improvement in that regard which will happen. The problem is that if you give too much fluid, what will happen? There will be a risk of cerebral edema. There will be a risk of hyperchloremic metabolic acidosis because you are giving a lot of chloride which is going to be pushed. You will also have, if you give too much insulin, what will happen, Sayan?
Too much insulin.
Yeah. You will have hypoglycemia and
hypoglycemia too early insulin, that will also cause cerebral edema.
It is a known risk factor and hypokalemia because insulin will push your potassium into the cells. So insulin excess will cause hypokalemia and hypoglycemia. So the most dreaded complication you are concerned about is cerebral edema. Now there are recent studies in the West which suggest that probably it is not related to how much fluid you give, how fast you give, what concentration you give. But our setting is different. The cases we get are much more severe than those studies. So we cannot extrapolate the data from there. So what we see is that if you have a severe disease, if you give soda bicarbonate, if you give more than 3 liters per meter square fluid, there is a risk of cerebral edema, which is very important. And it is the most common cause of mortality and morbidity in DKA. Now, what you can do is to do a slow correction and less fluid that will improve or you give mannitol in that situation. Now, hypokalemia is basically because of insulin therapy and you give potassium at the right time. The acidosis may be because of ketosis, lactic acidosis or infection and hyperchloremia. This is very important because once your treatment is continued, you may have persistent metabolic acidosis which is not because of DKA in that setting, and do not give soda bicarbonate at all in that regard. Now you can have infection, you can have thrombosis and you can have rhabdomyolysis. So why are you bothered about thrombosis and what action do you take to prevent it? What should not be done in a DKA?
Central line.
Don't put a central line because there will be a risk of thrombosis, and if you're putting a central line, start on heparin. That's very important. Rhabdomyolysis, how will it present? Fine. If there is a sudden onset pain in the leg, there is a rash, there is hematuria, red colored urine, high potassium, hypophosphatemia, these will be the risk factor for rhabdomyolysis which you have to be bothered about. Now this is a study which Neha had done in our 107 patients with DKA, and what we found that as against Western picture, lot of patients in our setup presented with cerebral edema at diagnosis. Now this is important. That means you have to be careful about cerebral edema right away. Those who have got prior fluid treatment were the worst hit in terms of DKA because they have received a lot of fluids and that was cerebral edema in that situation. So you have to be very cautious about those who have a very severe metabolic acidosis, which means the pH is less than 6.9 and you have received prior fluid treatment. So these two factors are important and these are what we have put in our own algorithm. So our algorithm for DKA is based upon ISPAT guidelines, plus we have got the information which is there, which has come up from this study in that regard. So when you talk about DKA management, there is a tightrope in being too little. So if you give less fluid, what will happen? There will be
persistence of dehydration.
Dehydration. What else?
The insulin.
It will take longer. If you give too much fluid, you will cause cerebral edema. If you give less insulin, you will have delayed cure. If you give too much insulin, you will have hypokalemia. So what would you prefer, Narayanan, having a bit of dehydration and basically staying in the ICU for a couple of more hours, or dying because of hypokalemia or cerebral edema? Of course, first. So what it means is that now we are talking about less fluid, less potassium. This is the basic mantra of DKA. Now, less is more. It is better to have less than having too aggressive treatment in that regard. Now, of course, in management, the first phase is just normal saline. Then you give even correction over 40 to 72 hours. You start insulin. Do not give an insulin bolus. That's out. You give potassium unless somebody is anemic, and dextrose when the blood sugar falls down below 300. This is the basic guideline. No role of soda bicarbonate and beware of cerebral edema. So now how do you monitor? Sensorium should improve. Hydration should improve. Urine output should always be more than 1 ml per kg per hour. one of the most deadliest combination is oliguria or ARF. If somebody develops ARF, that becomes really, really dangerous in that situation. Corrected sodium should be stable, potassium should be normal, and ketone should improve. Now, why I'm talking about all this is that each and every of these parameters is part of our DKA tool. When you enter that, it gives you what is to be done and what is not done in that regard. Now, I'll now bring in Dr. Hemang, who has done this very interesting study about how there are therapeutic errors in diabetic ketoacidosis and how we can improve on that. Dr. Hemang?
Yes, sir.
Yeah. You can switch on your, yeah, please. So you can tell us about the study. Yeah.
Okay. Yes, sir. Actually, as a pediatric intensivist, I usually face this diabetic ketoacidosis as one of the commonest complication, pediatric endocrinology complication in my ICU, and I did a retrospective study to look whether how much protocol deviation was common and whether it has any impact on the outcome in terms of morbidity or mortality. So what my study shows that only 18% of the patient were managed completely as per protocol, and 82% of the patient has a protocol deviation in form of missing of fluid bolus or giving too much less or too much more fluids, missing of potassium supplementation, not addition of the dextrose, even the sugar level is less than 300, and is shown that 17% of the children have two or more errors and 20% has a early insulin tapering, and this resulted into the significant preventable error in form of 60%. If we stick to the protocol, we can prevent 68% of the hypoglycemia and 42% of the hypokalemia and 66% of the dehydration. I did a further analysis of this study, and I have seen that if we do protocol deviation, then it possesses a 4 times more risk of developing clinically significant hypoglycemia and potassium level less than 3. So then thereafter we thought, how can we improve the adherence to the protocol, and thereafter we come with the conclusion that we should make a mobile application that provides a basic algorithm that how to manage a case of DKA, how to provide the initial treatment, and how to monitor the patient subsequently. So
I think very important point, Hemang, at this point is that these all are after a written protocol which is available, round the clock facility with pediatricians being available, and a consultation with pediatricians and pediatric endocrinologists and intensivists being there. So if this is going to happen at a tertiary level care, we would expect the situation will be much worse in places where all this is not available. Of course, what will happen in that most cases, we would be coming back and changing the treatment errors which are there. But by that time, already this becomes problematic. So the golden hour of DKA treatment is the first time. If you mess at that time, you will have a huge problem. And that's why the application concept was really wonderful and Hemang did develop. So you can just maybe go through about the application as to what we do in terms of various tools.
So this is a diabetic ketoacidosis management tool in which you have to answer a specific questions in form of yes or no, and it will take you through the management algorithm completely as per the ISPED protocol and with some modification which was done based on our own study. Sir, this is the diabetic ketoacidosis initial management analytic pathway in which we have to enter the weight, blood gas, potassium, ECG, and thereafter if we do a simple calculation button, it will provide a algorithmic prescription format which is easily understandable. First, it will interpret that DKA confirmed. Now we have to follow the protocol, which fluid is to be given, how much amount of the fluid bolus to be given, and then in subsequent phase, what was the rate of the fluid and how much potassium need to be added, what should be the dose of insulin to be started initially, and what should be the subsequent monitoring protocol. Next, in subsequent monitoring, there is one of the DKA follow-up tool in which you will have to enter a weight and hours since the treatment. So thereafter, subsequent point will start the question, and as per the question, if you will put inputs, it will suggest the action in form of what fluid we should continue, and whether the child is in cerebral edema or not, and how to manage that immediately, and what should be the potassium in the subsequent fluids, and whether the child is at risk of cerebral edema, and whether the child is fit for transition to the subcutaneous insulin or not. And if it is fit, what should be the subsequent subcutaneous insulin dose?
So
Next.
this actually looks very simple, but this is actually a very complicated algorithm which Hemang had developed, and our tech team, Hemang and myself, had to spend a lot of hours to really go through each and every aspect to get out of it. But it's a very interesting tool. So I think we'll take now Sayan in, and he'll take us through the case, and Hemang and Sayan will discuss as to how this case should have been managed and how our app suggests the management.
So a 10-year-old girl presented with a blood sugar of 540 milligrams per deciliter, had a weight of 30 kg, had a base excess of -18, the potassium level was 5.8, the pH was 6.9, and the dehydration was calculated as per severe diabetic ketoacidosis as 10%. So the maintenance and deficit fluids have to be calculated. We have two guidelines presently, one is ISPAD and the other is BISPED. So as per ISPAD, according to the Holiday-Segard formula, we get a maintenance fluid of 70 ml per hour for this kid. The deficit, which was 10% according to severe decay, and the deficit fluid per hour is 60 ml, 65 ml per hour for this child. According to BISPED, which is the new 2020 guideline, which says for a child between 20 to 40 kg, it is 1 ml per kg per hour, and the deficit fluid calculation remains the same for this as well.
So which one do you prefer, and which one does our study talk about, Hemang?
Sir, our study is based on the ISPAD, and I would like to manage the child as per the ISPAD protocol.
Yeah, the reason for that is that when you talk about BISPED protocol science, we are talking about classification of less than 7.1 and more than 7.1. Now, our child is 6.9. So they only see patients who are 7.1, not very severe. That's why they have used a milder protocol. If you use this protocol, you will have much longer time to correct the hydration. So your fluid will be much less and these children will be more dehydrated. So that's why we have chosen ISPAD, which seems to be quite optimal in that regard. Yeah.
So as the child wasn't in shock, a normal saline of 10 ml per kg was added, and the total fluid comes out to be 135 ml per hour with potassium as per recommendations of 40 millimoles per liter. And the insulin at the dose of 0.1 units per kg comes out to be 3 ml per hour according to the dilution present.
Now, often these calculations may be difficult. So what we have done in our application would be that all you have to do is to put the data as to whether the ketones are there, the pH parameter, the CO2, all these parameters are there, and based upon that you will have the uniform output, which is just you put the potassium, dehydration, ECG, and then modified GCS, and you get the result, and that is more like a actual prescription. So it's decay is confirmed. You give this much fluid, this much hydration fluid, insulin dose, and suggested monitoring. So, Hemang, why are we putting so many parameters in the beginning? What do they help us about? Each parameter, can you please explain? What does pH help? What does potassium help and all?
Yes, sir. If we talk about each and every aspect, actually, main thing is whether these parameters put the child at a risk of cerebral edema, and if the child is at risk of cerebral edema, we need to have a gradual correction over 72 hours. And if we another thing is, if the child is less than 1 year, then we need to provide a less amount of insulin, that is 0.05 unit per kg per hour. So in our app, it is inherently it is in our algorithm only, and the user doesn't have to worry about that.
So very important, this child at a pH of 6.9 has got dehydration which is there, and all those parameters put him at a high risk of cell-bleeding. Now what it has done is that it has automatically taken it to 72 hours. That's why your figure and this figure is slightly different. But this you don't have to bother about, you will just calculate. So there are already feeded so many, all the things that you feed are relevant. If you say that there is hypokalemia, there will be different management. We have put ECG also. So if suppose ECG is not available, Hemang, what should be done?
Sir, we might put ECG normal. If we have a serum potassium level, it will accept that serum potassium level as a appropriate value, and it will suggest the appropriate action.
Yes. That's basically the parameter. Carry forward.
So not only does the app provide the initial management, as sir already mentioned, it also helps us in the follow-up of the patient. So the same patient at 8 hours presented with blood sugar of 200 milligrams per deciliter and had a base excess of -12 at this point of time. So we know according to the protocol that when the blood sugar is less than 200, we need to add dextrose, which is 10%. When the blood sugar is between 200 to 300, 5% dextrose should be added. But no dextrose needs to be added when the blood sugar is more than 300.
So what should we do in this case? If you just put into the parameters, you will find that there will be if you put all the data, it will ask based upon the duration of follow-up, it will ask about specific data which is there, and based upon that data, you will take a decision as to what is to be done in that regards, and then you will get the final results which are there in that situation. So what you are seeing is that it says that you continue 40 millimoles and you have to change the fluid to 10% DNF. And there is a fall in corrected sodium. So we talked about corrected sodium as an important parameter. Now just by putting it initial and subsequent, you get this fall in corrected sodium as important. So there is a risk of cell edema. It's already talked about that. It's alerting you. So that becomes important. Yeah. Hemang, what do you suggest about this? Yeah.
Actually, main thing of worry is the development of the cerebral edema, and we in this app we have incorporated corrected sodium as a main parameter to warn us about the cerebral edema. And in this patient, as shows that there is a significant fall in the corrected sodium, we should keep a close watch to the cerebral edema, and we should keep the mannitol on ready if any fall in GCS occurs.
Okay.
So the same patient, again at 20 hours, presented with happened to have a blood sugar of which was 190 milligrams per deciliter. The base excess was -12 at this point of time.
So what do you think, Hemang, is happening here? He's 20 hours, which is very, very far. Still there is acidosis. Should we continue treatment? Sugars are normal, child is stable. What do you suggest?
As sir, this image shows, ketone usually resolves within the 10 to 12 hours of the management, and acidosis will take a time of approximately 24 hours. And this acidosis is usually hyperchloremic metabolic acidosis, and it usually self-resolving. We do not need to do anything for that.
Yes, so I think this is very clear-cut case of a hyperchloremic metabolic acidosis. So you have to look at the ketone levels. If the ketone levels are less, this thing is considering that you look at the lactate level. If your lactate is also less, this means it is a hyperchloremic metabolic acidosis. What is chloride load? Iman, what is chloride load?
No, sir, no idea.
So that will be another way of looking at in terms of the same hyperchloremic metabolic acidosis, which we have not put it here because then you have to take chloride also. But if you basically look at these parameters, you will get the idea from carry forward. So now post DK, this child has been put on sliding scale, which is something which is commonly done, and the sugars are fluctuating. So do you agree with that science approach of sliding scale? Sliding scale is that you give insulin 6 hourly as per the blood sugar, which is a very, very common practice. Do you think it's a good practice or not?
No, sir. So we have to, as we know, the post-decay phase is our insulin resistance phase. We have to have high insulin levels and we have to adjust it accordingly.
So this sliding scale is basically a reactive strategy. You react to a particular sugar, If it's 300, you give 6 units. If it is 400, you give 8 units. This is not going to work. You will take days for it to improve. So that's why, Himang, what do you think is the best approach to start off?
Basal bolus regimen of the diabetic ketoacidosis subcutaneous insulin management.
So you need to give a basal insulin, and ideally this basal insulin should have been given a night before to take care of it, and then you give the rapid insulin. Now, in our situation, what we need to do is that we should switch over to glargine and lispro, and then at a high dose. Now, often people find it difficult, so what we've done is that we put a very simple calculator. You put the weight, pubertal status, decay or not, you will get the dose which is required. So better to go ahead with this rather than going ahead with a lot of these confusing algorithms for sliding scale, which is of no value.